And as you know, there are lots of challenges in twins apart from preterm delivery and increased morbidity, mortality. And then on top of it, you have monochorionics as well, which keep us on our toes all the time. So we do know that we have reached a phase where we cannot miss twins as long as they've had a scan, particularly before 15 weeks. And largely what we are going to discuss is all there in the guidelines. And ultrasound is the basis of the management on twin pregnancy. So what we have done is we have taken a few cases, and I'm just going to run through the cases, and then when it comes to discussion, I will let Bijoy take over that, and then I'll put in my little bits and pieces. So I will just run through the cases. So first two cases. The first one is a 37-year-old IVF pregnancy, self-embryos, discordant NT in the first trimester, high risk. And obviously, you know, she was offered a double CVS, and they were not keen on that, so they decided to do an NIPT. First time, no result. Second time, no result. Then did the anomalies. They said anomaly scan, but they said we don't want to do the amniocentesis, then we will defer it to 30 weeks. And then at 28 weeks, there was growth restriction in one baby, and they declined an amniocentesis again. Postnatally, the growth restricted baby turned out that was, postnatally one baby was well, and the second baby, which was growth restricted, had increased anti-absent nasal bone, turned out to be Down syndrome. So growth restriction also can be parts of spectrum of Down syndrome, right? The second case, DCDA twins, again referred with discordant nuchal translucency, 3.6 as you can see. That's the same increased NT. We discussed all the options. In addition, at early anomaly scan, there was a linear insertion of the AV valve, and we did a double amnio, and that turned out that it was trisomy 21. We did a selective reduction at 18 weeks, and then she had a nice, normal, healthy baby, right? So two different cases with discordant aneuploidies. So I'm going to pass this on to you. So we put these points together, and we'll see where it differs between the dichorionic and monochorionic. So would we offer screening for aneuploidies, and when? Why?
Before that, I want to make a reference to the first picture that you showed. That was, I think, a decade-old picture.
Almost.
I have aged over the last 10 years, but you remain exactly the same. So that's something really commendable.
For the next 10 years.
So having put that out of the way, I would like to again start by thanking Thrissur and the Talk Society for giving me this opportunity here. And it's especially important for me this year because we have started practicing in Thrissur. So thank you so much for all your support and encouragement. So let me start by talking about aneuploidy screening in twins. The biggest confusion that we have is how do we screen for twins? All of us feel that the combined test is the best test to do screening in twins, but we should understand that the most important point here is that the screening differs based on chorionicity. If you're looking at a monochorionic pregnancy, we are going to give a single pregnancy risk, whereas when you're looking at a dichorionic pregnancy, you're giving two specific risks. But now with NIPT that has come in, there is this confusion as to which is the best test. Is combined test the best test, or is NIPT the best test? Now we can't talk about singletons here, but if you look at NIPT and twins, you will realize that NIPT may be the best test as far as combined test is concerned, because in combined test you have what is called as a high false positive rate of around 9%. Now when you have a high false positive rate, what happens? You end up doing unnecessary amniocentesis to make sure that those babies are normal. And in twins, you will be forced to do what? You will be forced to do a double amniocentesis to make sure that both these babies are fine. So it's very difficult to make a decision as to which test is the best test to do. But combined test has got its own advantages as far as cost is concerned. NIPT has got its disadvantage that you cannot separate these twins and say which baby is at risk or which baby is not at risk. But the middle path would be to probably use a combined test and understand that if the combined test comes out as positive, in a monochorionic pregnancy, you have a combined pregnancy risk, whereas in dichorionics, you have separate risks for fetus A and fetus B. So when should you screen for aneuploidies? The best time would be between 11 to 14 weeks. Do your NT and do your biochemistry, understanding that if you do a combined test, you're going to have high false positive rate. But if you don't want a high false positive rate, and if you want to do a test that is slightly more expensive, which has got a 98% detection rate, which is almost absolutely brilliant in monochorionic pregnancies because you're looking at the same placenta and therefore the cell-free DNA does not count. With a slight disadvantage in dichorionic pregnancies, then NIPT may be the best option. What would you suggest?
Timing of NIPT, right? Yeah. Timing is very important because in this, timing of any screening, particularly in twins, we have to think that if there is discordant aneuploidy or a discordant anomaly, the earlier we do a reduction, the better. And therefore, your screening and diagnosis also has to be early, right? So I am a promoter, of course, of first trimester screening. I do first trimester combined screening, I must say, primarily because NIPT is more expensive, actually not slightly, but much more expensive. Right? So that becomes the challenge, particularly in twins, because there is going to be a lot more expenses for them.
Yes.
So, but if they decide to do NIPT, then NIPT at the first trimester. And the other very important thing I make sure is I always do the scan first. And if the twins are concordant, that means both are similar, then do serum screening, whether it is first trimester quadruple marker or whether it is NIPT. But if there are discordant, like in the first case, we had a increased NT and we had a normal NT, right? So doing quadruple marker or doing NIPT will only delay the diagnosis. And if they are discordant, then I would much prefer directly going for a double invasive procedure.
Exactly in the same way as you would do in singletons as
exactly.
well. Yeah.
Singleton, singleton you have a little bit of time to fool around. I mean, not fool around, but waste a bit of time, it's okay. But in twins, you don't have that time, that luxury of time, because you don't want the reduction to be 18, 19, 20 weeks.
Too late.
It's a bit late, and the risk of reduction doing at 18 weeks versus risk of reduction doing at 14 weeks. Anytime 14 weeks is better than 18 weeks. And of course, we do the FISH for major aneuploidy. So the timing of screening again brings us back to the first trimester screening, which is the best time to screen for twins. Of course, you have already...
So if you have, let's say, discordant anomalies in twins, let's say one baby has got an increased NT and the other baby is completely normal. And as you rightly said, we screen, because we test them. We test them both because one is having high NT. Now my question is, do you test both of them in the same sitting? Yeah. Or do you test one, and the one that is frankly abnormal, and then say, let's wait for this result to come, and then let's wait till 16 weeks and then take it
no,
from there?
My first offer is to diagnose both, double invasive, right? Irrespective of whether it is monochorionic or dichorionic. Also, I would say, why? Because the chorionicity is not the same as zygosity, right? You can have about 20% of dichorionic twins are monozygotic, right? So phenotypically, one may have an increased NT, the other can have a normal NT, but genotypically, both of them can have the same chromosomal abnormality. So it is extremely important to test them both, because the worst thing I can imagine is that you have done a single procedure, you've reduced the abnormal, and then you give birth to another abnormal baby, right? Just because it did not show you the ultrasound features, right? So therefore, double procedure is the first choice. The second choice would be, of course, single procedure, the one which is surviving, or if the parents sometimes choose to do reduction, then reduce the abnormal and test the normal. Okay. But I will let you into a secret here, that I have an understanding with the lab that when I do reduction of the abnormal in such cases, because we go into the heart, I take a little blood and send it karyotyping for academic purpose, which I have an understanding with the lab because I sent them a few other samples with reasonable cost. Okay. They do it free of charge for me. And I tell the parents that if it is abnormal, then I will tell them. And other baby, hopefully we would have stored the DNA or whatever.
Okay.
Simple test, karyotype only. At the moment, I've not been able to negotiate an array with them.
Okay.
But it works, right? Occasionally it has worked where we have found that there's an abnormality there. But fortunately, because we have tested the other baby and it's normal, we have not had to do any further testing. So I think
ideally you would say that testing both fetuses is ideal.
That is the first
But then
choice.
if cost is your concern, then you probably would test the anomalous fetus or reduce the anomalous fetus.
And test the normal
And
fetus.
then if you have that lab that works.
No, test the normal fetus also. You reduce the abnormal.
Yeah, while reducing, to
while
test
reducing,
whether to test the abnormal or not, because cost is a concern.
Yeah, so the
then
patient
follow
doesn't have to pay for the cost of the abnormal one.
Abnormal
They
one.
just pay only cost for the normal one.
Okay.
But
So
this
if-
is a little secret.
So a takeaway would be probably if you have two babies, one is anomalous. If cost is an issue, we reduce the anomalous baby and do an
Test the
amnio at 16 weeks for the other
Well,
baby or
whenever.
CVS or whatever.
Just make sure that other
the
baby is normal
baby
as
is
well.
tested.
Because-
And there is no role for any form of other screening. That's it.
No,
Once you-
no,
Once
not
you
at
have
all.
reduced.
Finished.
yeah,
No,
once
no
you-
serum screening.
Yeah.
Once reduction has happened, no
There is
serum
no role
screening.
for serum
Even NIPT.
Yes.
Not even NIPT is a form of serum screening. Period. NIPT is serum screening. It's not a diagnostic test. It's nothing very fancy about
So
that
we
anymore.
have to do invasive testing
Yeah.
after we reduce one fetus. There is no role for any form of screening after that. And the reason why we are doing invasive testing is because 1/3 of them would share the same kind of genetic makeup as the fetus that we have reduced. And phenotypic expression may not be the same even if the genotype may be the same.
Correct.
Yes, okay.
Yeah, okay. So we will carry on. Labeling, extremely, extremely important when it comes to twins. And it is not like, because in the first trimester, as you can see, can I see? Oh. It came and it went away.
I think
Where is my laptop? Oh, there, okay.
yeah, okay.
Okay, oh. Okay, fine, never mind. Basically, what I wanted to say is there is a specific way to label twins in the first trimester based upon the orientation, the left, right, and the lateral orientation. And I've just put an example there. It is very, very important to be descriptive about which fetus is on which side, because the presentation can change. As you see, the baby is shifting up and down, so you cannot go upon the fetus. You have to look at the sac, where the sac and the membrane is attached on the lower segment. So we would say this is a dichorionic twin pregnancy with discordant growth. If there is discordant growth or discordant anomaly, you describe twin 1 is the one with the anomaly, or twin 1 is the smaller baby, or you go with the placenta, which has got twin 1 is on the maternal left. Where do I use the pointer? Okay, never mind, it's okay. This is a twin 1 on maternal left with an anterior placenta closer to the cervix. Twin 2 is on the maternal right with the lateral placenta, the smaller of the twin. So you have to get very descriptive in the first trimester describing the twins, particularly because they will go for a follow-up in some other unit elsewhere. So when we are looking at twins in the first trimester, we have to make sure that all this information is there.
And would you agree that more the number of markers, the better? Cord insertions, or if there's a single umbilical
the
artery
more
in
descriptive,
one,
yes, single umbilical artery, the one which has got an increased anti-absent nasal bones
No,
are,
they
they
variable.
are transient.
Yeah.
But still you can write, because the the increased anti and absent nasal bone, like in the first case, in the second trimester, we saw it was continuing to be absent nasal bone. So I know exactly which twin
Which
that
baby.
was.
So more
And
number
that
of
was good.
markers, more number of identifying features.
Yes, and all that has to be described in the conclusions, right? So we have already discussed this, invasive procedures. So I'll move on with the next two cases back to back. So this is referred MCDA with discordant anomaly, monochorionic with discordant anomaly. It can happen. As I said, phenotypically they can be different. MCDA with fetal height drops, omphalocele limb reduction defect, and one baby was normal, of course, right? And there was a pentalogy of control, and the twin one was normal. So we did an interstitial laser at 14 weeks and follow-up scans. and she delivered a normal baby at term. Another one, discordant anomaly with megacystis in a dichorionic twin pregnancy. Again, guarded prognosis for this one. We would discuss the possibility of aneuploidies, double CVS, single CVS, and pretty much the same line of management. Again, we did selective reduction, and she did a double CVS, did a selective reduction, and then delivered at term the single baby. Okay. Okay. Now.
So my question to you is that this was a monochorionic pregnancy, the one that you previously.
First one.
Yeah,
Second one.
Yeah, this is a.
Second one was a dichorionic.
The first one was a monochorionic, and the second one was dichorionic. So the difference basically being here is you use KCL for the dichorionic pregnancy, and for the monochorionic pregnancy you use occlusion techniques. So my question is, at 12 weeks, if you pick up an anomaly for a dichorionic pregnancy, you would straight away put in KCL and then reduce that anomaly. In monochorionic pregnancies, what would you do differently?
A tough one, that one. Because, see, the thing is, okay, so there are, because one is the method in which you would do a reduction in a monochorionic twin pregnancy is different to a dichorionic. It's not as straightforward. And there are various cord occlusive techniques. There is interstitial laser, there is RFA, and there is bipolar cord coagulation. So let's leave bipolar cord coagulation because that is done only after 18, 19 weeks, because before that the instruments are thicker, so you would not do. I would think pretty much RFA is the same. The needles are thicker and you would not do. My feeling is that if we are going to reduce less than 16 weeks, interstitial laser is better, because the needle that you use is the same as the CVS needle, the same CVS which we use in first trimester anyway. And we pass the laser through that. Now, sometimes the access in the first trimester can be very difficult to reach the abnormal twin, particularly if it's the presenting twin, if it's twin 1, which I had one recently. So we had to wait for the baby to grow into the higher up and then do a reduction bit later, because I don't want them to carry the risk of monochorionicity.
No, my question is, if there is an anomaly, for example, there is a hypoplastic left heart in one of the babies in a dichorionic pregnancy. So there's no confusion, we'll put in KCL. Yeah, but what criteria would make you decide that, okay, this anomalous baby I would want to reduce, whereas this anomalous baby in a monochorionic pregnancy, because there is this risk of co-twin demise, I might just leave it alone. And this is the one that I will definitely want to reduce. Is there any criteria that you look at?
No, actually no. Because I don't want them to take the complications of monochorionicity, right? Because come 16 weeks onwards, the complications of monochorionicity will start increasing. So for an anomalous baby, I don't want them. My criteria is how easy I can get access to the anomalous baby and as safely as possible try to reduce. Having said that, sometimes I have done, for the example, that one I have done at 14 weeks, whereas currently I have got one where at 16 weeks also I'm sitting because the placenta is completely covering the anterior wall, and there is some TTTS, but I have got the abnormal baby also sitting there below where access is difficult. So I'm just hoping that I'm seeing her every week, and 1 week I will get the access and just do it. So it will vary from patient to patient, and I think there is no right or wrong answer to that, I feel.
Our approach is slightly different as far as this is concerned, because if you have an anomalous baby in monochorionic pregnancies, we're looking at a slightly higher miscarriage rates, because we're looking at double intrauterine fetal demise because they share the circulation, irrespective of whether we are using cord occlusion techniques. So for us, the criteria is basically 3 things that we look at and to decide whether we will go for reduction. The first thing is whether this anomalous baby is going to put the other baby at risk. The best example would be a trap fetus. A trap fetus will put the other fetus at risk, so I know I have to definitely do a laser for the anomalous fetus. The second thing that we look at is this an anomaly that will need long-term care? For example, if the baby will be born and the baby will need palliative long-term care, for example, a very bad spina bifida or a Dandy Walker malformation, I know this does not put the other baby at risk, but the child will be born and the child will require long-term care. So then those babies I will reduce. The babies that I won't reduce are the babies that are not putting the other co-twin at risk and are uniformly lethal across the board, they will be born and they will not survive. The best example would be a bilateral renal agenesis. You have bilateral renal agenesis in a monochorionic pregnancy. I would probably counsel the parents saying that, okay, this baby is having a lethal anomaly, not compatible with life. Yes, there is a risk, maybe 10 to 15% risk of monochorionic complications, and there is around a 10% risk of cord occlusion techniques. I will give them the option and ask them to decide whether they want to take that risk or go ahead. And if they say that they are willing to go ahead without doing the cord occlusion technique, I would probably push them in. But yes, again,
actually, in a bilateral renal agenesis, it would be difficult to do a cord occlusion.
No, laser.
Because you have you have to do a laser.
Yeah, you have to do an interstitial. It will be easy
actually,
to do
it will be much easier.
Easier to do an interstitial laser. So whether to do an interstitial laser or not at that point will absolutely decide.
Will vary from patient to patient. Will vary.
So both options, I think, are fair enough, depending on how you counsel your patients and what the patient desires.
And there are challenges based upon the anomaly, the complications of monochorionicity. Don't forget preterm delivery, because preterm delivery in twins, big challenge. And of course, the method of occlusion. Cell-free DNA is out, right? We agree. We all agree that where there is an anomaly, you would not do a cell-free DNA test. That is a strict contraindication. I would say an absolute contraindication to do a cell-free DNA testing, because here you want definitive testing, definitive diagnosis. So, okay, so I think we have pretty much covered that. Patient choices also we have covered. And reduction and risk of reduction, not so great, not so high anyway. If I can move the slide further. Am I not aiming right? I thought I could do better than this. Top button is the thing.
Yeah, now it's going back.
Okay. No. Move forward. Okay, fine. It's moving now. Okay, so the risk of reduction post CVS, sometimes we have to do an invasive CVS and then do a reduction, is also pretty much the same. Losses are not so great, and we have pretty much covered that as well. So I'll just take you through the next two cases. This one was a DCDA with discordant growth, and there was absent endosolic flow in fetus 1. Fluid was normal in both the babies, and you can see baby 2's growth is pretty low, much less than the twin 1. Okay, can we move please? I can feel it buzzing, but okay. So there was an intrauterine demise of twin 2, and twin 1 was delivered at 34 weeks, preterm delivery 2.2 kilos. So that was one. Second one was, sorry, this is TTTS. Okay, fine. But this one also was SFGR also. Yeah, this one was referred to us as twin-twin transfusion syndrome, but actually it was a SFGR. You can see there's a discordancy. The top two images are twin 2. The left image is twin 1, twin 2. It's got a bit mixed up there, names. But there was a discordant growth. As you can see, the AC at the lower, the two abdominal circumferences. So next, okay. In addition, there was absent nasal bone and HEB in one baby. So there was, next please. Okay. So we had a quite abnormal umbilical artery Doppler in the abnormal baby, twin 2, the lower one, which was type 3 selective growth restriction. Next please, and they were offered selective reduction, radiofrequency ablation, and they had a radiofrequency ablation, and post-procedure things went well, fortunately, and delivered at 34 weeks, 1.7 kilo baby, doing well. So, should all twins have growth scans?
Yes, definitely. Everyone has to have a growth scan. And as far as
all twins,
I just, since everyone knows about growth, I just want to just air this question. We all agree that in monochorionic pregnancies, there is a single placenta. There is a single placenta, but one baby is growing well, the other baby is not growing well. And we have also been taught that when the umbilical artery is bad, it tells us that the placenta is bad. Isn't that what we have been taught? When the umbilical artery is showing absent end diastolic flow, 60% of the placenta is damaged. Then can anyone explain why one side of the placenta is good with good umbilical artery and the other side of the placenta is bad with a bad umbilical artery? I think that is the basic fundamental principle where everyone goes wrong in selective FGR in twins, in monochorionic twins. What is happening here is that the sharing of the placenta is not equal, and the absent end diastolic flow that happens in the umbilical artery is not because the placenta is bad. The placenta is good, but the placenta is small. It's like, imagine you're pumping water into a big tank. If the tank becomes small, what happens? Will you have to put in more force to push water into that tank, the same volume of water? You have to use more force to push water into that tank because that tank shrunk in size. So that's what happens in SFGR. The placenta is good, the blood volume is the same, the heart is the same, and it has to push that blood volume through a small piece of tissue. And that's why you get an absent end diastolic flow in the umbilical artery. And once you know that, immediately you will know that there isn't going to be a sequential progression that happens in singletons or in DC twins. In singletons, when you see absent end diastolic flow, we counsel negatively to the mother. You tell them that there is an absent end diastolic flow at 20 weeks, so there's probably 3 weeks before this becomes into DV reversal. But in monochorionic twins, that same absent end diastolic flow will remain absent end diastolic flow for around 11 to 12 weeks, because the placenta is not going to deteriorate. The placenta is going to remain as it is. And that's the most important point on why it's important to understand the difference between SFGR and classical growth restriction that you see in singletons or in DC
They're
twins.
different.
Yeah,
They're
they're
different.
totally different.
And absent and diastole in twins can go on for weeks together.
Weeks together. So
right?
So the one thing I want to pass across is that a lot of people, I mean, we're getting a lot of referrals for RFA for SFGR. And I think you also would agree that majority of them have got good outcomes. Don't
Even
get
with
worried.
just simple monitoring.
Yeah,
They need
simple
good, close monitoring.
So don't get worried with absent end diastolic flow in a monochorionic pregnancy. Around 80 to 90% of them are going to go till around 30 to 32 weeks. And once they reach that magic number, we know that these babies are going to survive in the NICU. There is no need to take a drastic step of doing an RFA. And the problem is when we see absent end diastolic flow, we get scared and we think of all these other things. I just wanted to make that point
I think
very clear. Yeah.
umbilical artery Doppler important, yes, but also don't forget there is MCA Doppler and ductus venosus. Ductus venosus is very useful in monitoring twin pregnancies, particularly monochorionic twin pregnancies, both in the recipient and in the donor. That means both the normally grown baby and the small baby. And that will actually be more decisive as far as consideration for therapy or delivery is concerned.
And the fact is that DV is so good that it works both ways.
Yes.
It tells us when the heart fails in FGR, like when the heart is pumping and it begins to fail, the DV becomes abnormal. It also tells us when there is volume overload. When volume overload comes in, the heart is unable to push all that volume of blood outside, and again the DV shows a change. So when the DV is becoming abnormal or shows a change, it tells you immediately that this baby has got diastolic dysfunction, which is the first step towards systolic dysfunction and finally demise.
In fact, even after the DV becomes abnormal, you still have a little bit of
You have time.
You have time.
You have time.
And
That's the
therefore,
most important.
intervention in such situations should not be at the first point of diagnosis. I would look at the trending of it. You do weekly scans because you would have to do weekly. The moment you have discordancy, discrepancy in monochorionic, the scans become weekly. So you would do weekly scans and look for any deterioration. If there is deterioration, then you would intervene.
Yes.
Whereas sometimes they can go on for weeks and weeks together maintaining the same. And the same thing applies for TTTS also, right? Particularly stage 1 TTTS, even stage 2 sometimes, but stage 1, yes, they can go on for weeks together without doing anything at all.
And also I want to ask you, while giving your twin growth report, do you always make it a point to mention the discordance?
Yes, I do.
That is very, very important.
Very important discordancy. In first trimester also we have started describing the discordancy. In second trimester, third trimester, every time we monitor the discordancy. But at the same time, the parents look at discordancy between 20% and 22%. Now let's not worry about that. Plus minus 5 to 10% is allowed.
I always give them the example of sharing their property.
Yeah.
So if you share your property, sometimes you don't share it equally, and that's what happens right from the intrauterine life. You never
Property,
share.
wow. I tell
You
them sharing a plate of
no,
food.
you never share them equally. So someone usually ends up lucky, and so everyone at the end is not going to be happy. So it's always going to be like that.
Excuse me,
I,
Dr.
we've
Prathima,
got
Dr.
only 10
Vijay.
minutes.
Yes.
Yeah.
Sorry for interrupting. Even though you'd like to continue this dialogue for some more time,
Almost
actually
done.
we are
I think we'll
nearing
wind
the end of the session, only 1.5 minutes left.
Yeah, yeah.
Okay,
I
thank
will
you.
finish it off.
Finish
We'll
off with
finish it off.
TTTS.
Yeah. Okay, so let me just go through that. So this is a classical case of twin-twin transfusion syndrome. We know that there is discrepancy in weights as well, discordancy in growth, 30%, and oops, if I can move the slide. Right, okay. So did a laser, and there was 1 kilo difference between the two babies, and they did well. So I think we should, when should we start screening for complications in monochorionic twins? Pretty much, I think we have said
we've
the
said all that. I think
first
one
trimester.
message that we can, since we are short on time, I'll just give one message about TTTS. I don't think in this day and age we should even think about termination for TTTS, because TTTS has got good outcomes today because there are multiple centers that are doing laser, and I don't think we need to think about pulling the rug out of these babies' lives. But what I think is that whenever you see a case of TTTS, always remember to look at the cardiac function of these fetuses. That is what decides probably in stage 1 TTTS and early forms of Leiker discordance, where it's not frank TTTS as yet, but the cardiac status will tell you that whether this baby is going into TTTS or not. And if you catch them early, there is a good chance that these babies will survive. And the ones that don't survive are the ones that are picked up late. I'm sure you would agree.
I
with
don't decide before they will not survive at
that.
all.
No, I mean, if they're picked up too late,
Yes,
it's too late for
it's-
anybody to do anything.
Yeah, exactly. I mean, it's like a sinking ship, right? You have to catch it before it starts sinking. And finally, I think you said cardiac function. I would say don't forget the abdominal circumference.
Yes.
In the first trimester, we have actually published a paper 3 years ago where we showed that the discrepancy in the first trimester, mainly in the abdominal circumference, actually could predict a lot of complications. Almost 80% of them had, complications when there was missed, when there was discrepancy in the markers. So again, finally, that all twins need to be followed up from after your 20-week anomaly scan every 4 weeks in dichorionic, every 2 weeks in monochorionic, and monochorionics after your NT scan from 16 weeks, every 2 weeks if there is no discordancy, every week if there is discordancy. And I think we both fully agree that all twins should be monitored in fetal medicine units,
Yes, I mean-
period. If we want really good outcomes, they have to be monitored by people who know how to look after twins.
It does seem a bit like selling your own profession, but
Yeah,
still,
but it is.
it is definitely the
Yeah,
truth.
it is certainly, because we are learning from twins every day. So thank you very much.
Thank you.
It was a wonderful dialogue. Thank you very much. And of course, as everybody knows, this twin pregnancy is a very challenging problem, especially the monochorionic ones. And to begin with, I was actually finding it very complicated. So fast you were going about aneuploidies. I am sure you all will be feeling the same. As obstetricians, we should be actually relaxed now because we have fetal medicine specialists everywhere now, isn't it? So we have every unit has now. So we should, the 11 to 14 week scan I find is very, very important as far as twin pregnancy is concerned. And not only for the chorionicity, to find out the aneuploidy screening and all the abdominal circumference, everything they told. And of course, we cannot manage twin pregnancy without a fetal medicine specialist. That's what the message I have to give you. Thank you so much.
Thank you.
Thank you so much, sir, madam, for that wonderful dialogue. But we know that this is not the end.